Thank you for the opportunity to present today. It's a little bit tough presenting after the grand rounds last week. I was so impressed by what the residents did at the Holman Research Day and the quality of the presentations. Roger presented some of the work that we've worked on over the past 2 years, and I'll give him a chance to do a little bit of an encore later this morning on something that he's passionate about. But it also gives me an opportunity to bring several of our projects together this morning. So we talk about the art of surgery. There are great master surgeons and clinicians who seem to make the right decisions all the time, incorporating medical knowledge, clinical experience, patient medical history, physical exam, labs, and their gut. Somehow they use their gut to make these decisions. I think their brains are taking in for all sorts of information. The details of these solutions are often a little different from clinician to clinician. It's influenced by how they weigh various variables, what their most recent experiences are, et cetera, et cetera. So it's a complicated process that there's parallel processing within the neurons of our brains. And it's because of the complexity of this decision-making that it's often called an art, the art of surgery. However, I think the development of algorithms and algorithms that help us make decisions, it pulls back the curtain a bit on these and forces us to focus on the components of the decisions. It forces us to evaluate the input information and forces us to acknowledge how much we weigh the different variables, and they reduce the reliance on using our gut. But we always fall back because no two clinical situations are exactly the same, and so we always have a little bit of wiggle room. So I'm going to talk about projects that I've been working on, ranging from paired exchange kidney transplantation to improving fellowship matching to using artificial intelligence and machine learning as tools to improve our decision making. I think they're linked by a couple things. One, I'm always looking for ways to extend the benefits of organ transplantation to more people who will benefit from it, and to the use of algorithms to facilitate these decisions. So the first thing I'm going to talk about is optimizing paired exchange, which is something I got involved in very early on when I was just starting as faculty. Just a brief overview of the power of paired exchanges and now its most common variant, the donor chains. Everybody knows that receiving a living donor kidney transplantation is a very realistic option for many people. But about 30% of the time, patients are not compatible with their willing and healthy potential donor. So these incompatible pairs are then placed into a database of other incompatible pairs and in an attempt to find a match for them. Donor chains are specifically initiated by generous individuals who want to donate a kidney to start a chain, but don't receive any kidney in return. So they don't have a loved one that needs a kidney and not receiving one in return. These are called non-directed donors. Non-directed donor initiated chains have multiple benefits, including not needing to start all the operating rooms simultaneously because it's done sequentially. And you have a significantly higher number of potential solutions, higher number of potential chains that can be identified within a database because you have this additional donor starting the chains. So in this example, I have patients represented as rectangles and donors represented as ovals. And we have the non-directed donor donating to one pair, a recipient. That recipient's donor gives to another recipient, and so forth and so on, until there's no one left to give a kidney to, where we now have a bridge donor, or plus one because the non-directed donor started the chain. This bridge donor can now start another chain or can donate to the wait list. Now, this diagram is somewhat deceiving because it's unlikely you'll ever find a match for everybody in a database of any reasonable size with one massive chain. So different solutions or different potential chains all need to be prioritized. Therefore, an algorithm that does this has to first identify every possible solution and then prioritize every possible solution. And this forces the designer of that algorithm to explicitly review How do you evaluate each exchange? Do you favor patients who've waited the longest? Do you favor the youngest patients? Do you favor patients that are the hardest to find a match for, like blood type O patients or patients with antibodies against the large number of HLA antibodies? Or do you favor getting more transplants done? And how do you prevent disadvantaged populations from becoming more disadvantaged? One of the keys we realized early on in designing these algorithms it was that it was very important to be transparent with the community. The community needed to have some sense of the decisions being made to prioritize these kidneys and these exchanges, because transplantation is always a very public the transplant is always very public, and there's always lots of data towards that in terms of outcomes. So this is what we did. We published the results of the first 100 transplants facilitated by the largest national database of incompatible donors. And one of the main worries was that A recipients were going to be hurt by the change, since they're the hardest blood type to match. However, what the change did was they released blood type O donors who are HLA incompatible with the recipients, but could donate to other patients in that database. So as a whole, O patients were not harmed. However, as we were publishing this, and other national databases were being formed, and so there actually was some national tension between the databases and between various programs, as we all had to figure out how to work together, because in these exchanges, kidneys were being sent across the country from New York to California to Florida to the Midwest. And so that we had to develop some sort of trust amongst all the centers that things were being done fairly. So therefore, we decided that a national conference, consensus conference, had to be convened. So in 2012, I co-chaired a national consensus conference that was held in Washington, D.C. The conference brought together about 40 different people to really talk about the stressors of paired exchange. I think we came up with some common protocols that we could all follow, and probably more importantly, establish sort of pathways of communications and protocols for communications to develop trust. So it's pretty common now that people feel comfortable procuring even living donor kidneys and sending them to other programs, and other programs are confident enough in the surgeons doing the donations that they're comfortable using those organs. Paired donation has grown dramatically in the United States since the first case in 1999. Stanford we did our first case in 2008. At that point, exchanges accounted for about 1 in 25 living donor transplants. When we had the consensus conference in 2012, the number was about 1 in 22 living donor transplants. Now it's almost 1 in 6 living donor transplants are through paired exchange. At Stanford last year, we actually approached close to 1 in 4 living donor transplants were from paired exchange. So the algorithms that you use to identify change and prioritize chains within an incompatible a database of incompatible donors have to balance justice and utility. Utility is sort of a measure, as people know, a measure of overall benefit. One of the ways to measure this is minimizing the mean time to transplant. So if you can minimize the mean time of transplant for a population, you can get more transplants done, and that's sort of a measure of utility, getting more transplants done quicker. Equity is sort of looking at fairness, and one of the ways to understand fairness in transplantation is equalizing the waiting time to transplant, no matter how hard you are to match. So even if you're blood type O, you're a little bit easier to match than a blood type. You're harder to match than a blood type AB. So you want to set up a system so O's are not vastly disadvantaged over ABs. Or if you have lots of antibodies against HLAs, you might be harder to match. So maybe you should get prioritized in the system. So measuring out how hard you are to match is a real problem and a challenge. And we started with a hypothesis that equity and utility can be influenced significantly by the matching algorithm itself. There's a grad student that saw one of my talks, and he wanted to work with me on his PhD thesis, Dr. Owen Liu. He was an operations management graduate student. And so he wrote his PhD thesis on trying to accurately measure the difficulty of a pair finding a match in the database. So if you look at this diagram, each node represents a donor-recipient pair. The first approximation of difficulty match is how many donors, so here's your donor pairs and here's the recipient donor pair of interest, how many incoming arrows that recipient has. So if this recipient has 2 out of 3 compatible donors, they have a sort of match power of 67%. A second approximation would actually take into consideration the donor. So this recipient can't receive any of these unless the donor can donate. And in this case, the donor can only donate to one recipient. So 33% of the database. So the paired match power for this pair is actually 67% times 33%, or 0.22. So paired match power focuses on the local connectivity of this pair, with the notion that a more connected pair is easier to match. However, if you step back a bit, these donors that are compatible to this recipient are actually not available unless their recipient also receives an offer. So the strength of this pair actually relates to the strength of this pair, and specifically this recipient. And this is where Owen's PhD came in. He wanted to step back and look at the nodes iteratively and calculate the strength of the central pair here by looking at the strength of the other pairs and the other pairs beyond that. And this is actually very similar to how Google became so effective at ranking web pages back in the late 1990s. What Google did was calculate the importance of a website, not only by how many links from other websites it received, but how important those links were from another website. So they did an iterative calculation to determine the strength of each website. Similarly, Owen came up with an algorithm to measure the strength and matching power of this central pair by first calculating the power of each node by incoming and outgoing arrows, and then using that information to recalculate the strength of the initial pair by weighing each of these arrows coming in based on the strength of the node. So he called this the iterative paired match power, IPMP. So we were able to publish this last year in the Journal of Medical Decision Making, and he showed that using this algorithm, we're much better able to predict how soon or how powerful a pair that has been placed in an incompatible database how difficult it was to get a match for them. So this leads me to second project, which was fellowship matching. And again, this was came out of a challenge that I faced when I was a program director, actually. In 2016, we had 3 superstar residents interview for pediatric surgery fellowship. I don't want to even think about how many days of their chief year or their 4th year they missed going on interviews, but by their own report, they spent between $10,000 and $20,000 on interviews that year. And they each went to over 20 interviews all over the country. And mind you, they were in the top echelon of candidates in pediatric surgery. Dr. Wapner, in her role as a fellowship director of the breast fellowship, and I got to thinking about there had to be a better way. So we enlisted colleagues in engineering and economics to help us think about and model potential solutions to this. So we came up with the concept of the interview match. And this is another way that an algorithm can facilitate decision-making. So here's the basic concept of an interview match. And on the right side here, we have the current system where candidates apply to programs, programs decide who they're going to interview and invite the candidates to interview. The interviews take place, and then candidates and programs each submit a rank listing to the match algorithm, and then the match algorithm assigns people to programs. In our proposal for an interview match, candidates apply to programs, and then programs and candidates rank each other respectively. So based on their initial ranking, an algorithm assigns interviews to a limited number of slots. These interviews then take place, and then, like in the current system, the candidates and programs submit rank lists for, and then there's a match algorithm, the same type of match algorithm at the end. So we were able to publish this proposal in JAMA with Dr. Ashwagi and Dr. Wapner. Dr. Al Roth from economics also contributed significantly to this, to the thought process. So here are some of the results of the initial modeling. So in these models, we wanted to mimic pediatric surgery because that's where we felt that it was most challenging because it was such a competitive fellowship. So we had 84 candidates, 42 programs. The candidates were all ranked into 3 tiers based on hypothetical applications. And then the simulation was run thousands of times with a hypothetical normally distributed candidates. On the left figure here on the y-axis, we show the number of interviews, and then in the x-axis, we're reducing the interview capacity. So reducing the number of allowable interviews from 30, which was the average number of interviews pediatric surgery candidates were going on, down to 5. And not surprisingly, as you obviously reduce the number of slots, the number of interviews goes down. It seems like the different tiers of candidates sort of proportionally goes down too. So the top tier candidates in blue have to go on fewer interviews, as do the mid-tier and the third tier, the green. Now that's not a surprising result. You reduce the number of interview slots, of course, there's going to be a fewer number of interviews. On the right side here, we're looking at the filling of interviews of programs. So in the final match, there are 42 positions, and we want to see whether or not all 42 positions fill as we reduce the interview capacity. And the striking result here was that when we ran this algorithm thousands of times, it appeared that almost always, as we reduced the capacity down to 10, all the slots were filled. So there was no problems filling slots. However, when you reduce it down to only 5 interviews per program, there were occasions when we ran the algorithm that some of the slots were not filled. Now, when you think about it, this is not surprising because the interview algorithm assigns candidates to interview at programs where they're likely to match. So you have expressed some interest in them through your ranking, and the program has expressed some interest in you through the ranking. So each interview is more likely to lead to a match, which makes the system a little bit more efficient. And the other interesting thing is here, especially the top tier and the mid-tier candidates don't seem to be harmed by reducing the capacity. There is a slight reduction in matching of the third tier candidates, but for the most part, neither candidates nor programs seem to be harmed. So this modeling is based on a lot of assumptions. It's very preliminary, so we need to collect some data. We need to know how many programs candidates interview at on a regular basis. We need to know what the impact of interviews are on the final outcome of the match. So we're actually obtaining data both from the NMRP and from a company that provides scheduling software for all of pediatric surgery programs. we're hoping that this gives us a precise understanding of who gets interviewed at which programs, and how many interviews candidates go on, and what their final ranking is. So important questions that we have the answer is: how important is the interview? How much agreement is there on the ranking of programs and candidates? It turns out some of our preliminary modeling suggests that if there's not a lot of agreement on what the top candidate, who the top candidates are, or who the top programs are, you have actually more opportunities to find mutually beneficial and mutually desirable matches. And then you always want to make sure when you implement these algorithms, you want to make sure that certain candidates or programs are not disadvantaged compared to the current system. All right, now I'm gonna, this leads me to the work that I spent most of my research time on now, and that's working on an objective assessment of donor liver steatosis. And this is work that Raja presented so nicely last week. But our goal is to use an artificial intelligence algorithm to detect histopathological features predictive of transplantable donor livers. So we can do better, and we have to do better. There is a serious organ shortage in our country. There are so many people that need livers, and so many people that are dying waiting for livers. So in 2017, over 7,000 livers were transplanted in the United States. About 700 of those patients died within the first year after transplant, and 6,400 patients died waiting for a liver transplant in 2017. At the end of 2017, 13,239 patients were still waiting for a transplant. In that context, about 742 livers were procured but then discarded after they were removed from the donor. Many of these discards were because biopsies of the liver were deemed to be make the liver too high risk to be transplantable. One of the most common reasons to discard a liver based on biopsy is that it has too much fat content. So how can we, this sort of begs the questions, how can we push the limits of usable donors? And are we using and discarding the correct organs? Raja presented this work last week. He focused on the first stage of this project, so I'll quickly move through this part since he gave a great presentation. We took a characteristic of donor liver, steatosis, which is thought to correlate with outcomes, and asked whether it could be better assessed using a computer vision algorithm. As Raja said, AI and machine learning are higher level statistical programs of varying complexity. Modern computing power allows us to have algorithms to run these models over and over again. And then we can use the output of these models to train the algorithms until the output approaches the gold standard. And so some of the initial conclusions that Raja presented were that AI can feasibly quantify steatosis and digitize donor liver biopsies. And more importantly, that AI was better able to discern which donor livers were at risk for early graft dysfunction. So the AI algorithm is actually pretty effective at estimating which livers were going to have some problems early on. So then he ended his talk about can AI be deployed as a point of care tool in the field, which is a great segue to the part I want to talk about now. And that is, how can these algorithms be actually implemented in clinical practice? So Raja presented last week several of the AI models and how they can effectively label globules on a slide. So we have the original image, we have the pathologist labeling of that image, and this is the gold standard that we use to train the algorithms. And then here we have 4 different algorithms used. As you can see just by eye, the UNet model seems to provide a solution most similar to the pathology labeling, which is the gold standard. The shallow UNet also performs pretty well, not quite as well as UNet. The benefit of the shallow UNet is it's a little less complex and requires less computing power. So if you want to build a mobile device, you might consider using the shallow UNet model instead of the UNet model. To be clear, the gold standard is the pathology labeling, and achieving the gold standard is the goal of this labeling. In terms of where precision gets lost sometimes when pathologists are estimating the percent steatosis is in the next step, which is basically dividing the area of the fat globules by the total area of the tissue. It's this estimation that I think leads to a wide range of interpretations of steatosis. So let's look at the workflow that's necessary to process an image and come up with a solution. The solution. So here's a simplified workflow. You need to acquire the image. You need to do some preliminary processing of that image. In this case, it's just converting it to a grayscale. Then you feed this grayscale image into the algorithm, and it spits out what's called a mask. And the mask basically just shows you where the fat globules are. It's either white or black pixels, the white representing fat globules, black representing anything else. Then you can superimpose this mask on the original image to show you where the fat globules are. The computer then does the simple division, like I said, to decide what percentage of this tissue is composed of fat globules. So let's look at a real situation. It's 6:30 a.m. in Southern California, and our donor team is finishing up a run in Southern California. They've been operating all night at a small hospital. They even saw an old friend, Hari, who's a graduate of 2012. And at 3 a.m., they really needed a liver biopsy because the liver would look fattier than advertised. However, pathology was not available, or the pathologist lived too far away, or the pathologist didn't have the same type of expertise they were lucky enough to have here at Stanford. So they were not able to get a read on that slide. So boy, it would have been nice for them to have a portable device to read that percent steatosis. So what would that ideal device do? It would need to be reproducible, need to be accurate, need to be easy to use, always available, portable, and secure. So it has to be HIPAA compliant. Which gives me to the next point. I want to talk about the point of care devices. So with the technology today, you could have a standalone device, or you could have a mobile app. You know, our mobile phones are so powerful now. They have cameras, they have processing power, and they may be able to do this for us. So we decided to go use both strategies in parallel. I don't know, some of you may remember this device. This was the Flip Video, which was introduced in May 1st, 2006. It became the best-selling camcorder on Amazon in 2007. However, in 2007, this device was first introduced to the world, and it also had a camera and then a video, and over time, the camera and video became quite powerful. By 2009, the Flip Video was sold to Cisco. Cisco promptly closed the product down because of the power of the mobile phones. So like I said, we're sort of working on these two projects in parallel. So first, looking at the mobile phone. You can imagine that you have an app residing on your phone. It collects an image. There's all sorts of attachments where you can attach your iPhone to the microscope and take high quality images. These images would have to be processed by the artificial intelligence algorithm. This algorithm could either reside on the mobile app, or this algorithm could reside in the cloud and get processed in the cloud, and then the results sent back down to the device. Here are some mock-ups of Steatosis app prototype, where you select an image to get processed. It spits back the mask of that image and the % fat content. So using some of the grant money that I got earlier this year, the technology grant, I was able to hire a programmer and an engineer to help me out with this, and I have a little bit of a demo here of the mobile app. Here we click on the app, open it up, decide we want to study steatosis. We then load up an image, and the app processes it and spits out a mask and a % content. So this is the very beginning. We're sort of moving along pretty quickly here. We're trying to figure out whether or not the algorithm has to be hosted in the cloud or on the phone. And this is sort of changing. There's so many open source packages and software, freely available software now, that allows you to do quite a bit of processing on the mobile apps. So a standalone device has some benefits. It's more secure because it's not necessarily connected to the internet or to cell phone service, and it's potentially more powerful. One of the reasons more powerful is that there are circuit boards now available that could have a GPU, a graphics processing unit. These graphic processing units are important for artificial intelligence because they allow a massive parallel processing that's required for these algorithms to run. So with this in mind, I came up with an initial sketch of what this device would involve. The device, outlined by the dotted dashed box, would have a microscope adapter, would have a camera, some memory, a GPU, and then an output to display how much steatosis. Based on this, we've actually filed for a provisional patent last fall. And like I said, I was able to hire some help to some design. And so we came up with this design, and pulling some CAD diagrams off the web of the GPU. So you can see the GPUs inserted here. There's a display here, the connections for the circuit board, and then right here is the camera to take a picture. You know, there's only one camera. The other cylinder here is just used to help stabilize the device on the microscope. And it might look like this, where the device sits on top of the microscope. We definitely have a lot of work to do, but it's been exciting bringing people together on this project, and I've definitely learned a lot from all the people helping me out on this. So next, I'm gonna let Raja talk a little bit. He's gonna talk about something that he's passionate about. As most of you probably know, he's very interested in surgical oncology, and he's sort of taking this project and taking advantage of the infrastructure that we've begun to put together to address something that he's passionate about. Raja?
All right, good morning. Thanks, Dr. Melcher. So briefly, I just want to talk about the foray we're taking to pivot from the work we've done looking at donor liver biopsies to see if we can use our artificial intelligence platforms to help us predict outcomes, specifically in resected neuroendocrine liver metastasis patients. So when we think about cancer outcomes, these can come across along 3 different dimensions. So first, we can think about the tumor biology. In neuroendocrine tumors, this can be defined by mitotic count, grade. In other cancer processes, this can be defined by somatic mutations. We think about chemotherapy as well, those that are locally delivered or systemically delivered, and radiation falls into this as well. And this can give us an idea about the tumor biology, whether it's responsive or not. But lastly, we want to add an interest of whether the hepatic environment plays a role for tumors that metastasize to the liver. We think about this in the context of colorectal liver metastases, but we should also think about them in neuroendocrine liver metastases, where there could be a debate about whether debulking is an optimal solution for these patients. And interestingly, with the association with non-alcoholic fatty liver disease and high BMI, this potentially could be a modifiable factor, as there is recent reports suggesting that steatosis is associated with increased risk for recurrence in certain oncologic processes. So for this part of our study, we're interested in looking at specimens of resected neuroendocrine liver metastasis patients. We have a time frame of January 2003 to December 2019, and we're interested in the primary outcome of disease-free survival, meaning the occurrence of death or recurrent disease. So for this study, we're taking these slides, we're digitizing them, reviewing them, and annotating them by two independent pathologists who are going to be annotating the mitotic count, Ki-67, and also the steatosis score. So as an example, here's an example specimen here, and you can see here is normal liver in the periphery, and then here's your neuroendocrine tumor that's been resected here. Let's zoom in, and you can see some well-differentiated pathology. And if you zoom in further, you can actually make out some mitoses. So this right here could be resembling metaphase, where you have your chromatin along the equator, relative to this cell right here where you've got dense chromatin that's not actively dividing like others. So in order to label this according to the WHO guidelines, pathologists actually have to review 500 different cells that are counted before they can say what the actual mitotic count is that can help determine the biology of the disease, which is obviously very tedious and is something that could be more objectively done in a quicker fashion. So for this study, we want to have these images split into two sets. One would be a training set that can help optimize a computer vision AI platform that uses the same fully convolutional networks we talked about last week and Dr. Melcher alluded to earlier this morning. And once we've developed these platforms, we would create a training set that we can determine if they're associated with outcomes as tightly as the same scores pathologists provide. So we have three different aims for this study. So one is developing a supervised platform that can score steatosis and mitotic count for these specimens of resected neuroendocrine liver metastasis patients. Aim two would be to develop a supervised AI platform that scores Ki-67, which is actually done on a different stain altogether for resected neuroendocrine liver met patients. And then lastly, after we've determined what the AI platform is able to perceive as the mitotic count, Ki-67, and steatosis, we're interested in whether the scores that the AI platform develops are more tightly or loosely associated with disease-free survival compared to what the pathologists have been labeling. And that's all I've got. Let me pass it back to Dr. Melcher.
All right, thanks, Roger. All right, so to bring it to a full circle here, this is a beautiful portrait that actually is AI generated based on a database of 15,000 portraits from the 14th to the 20th century. So you may or may not find this portrait brilliant. However, you should know that it sold at Christie's auction house for $432,000 in 2018. And if you look closely at it, the signature on the portrait is actually a mathematical formula related to the design of the algorithm. So this is an algorithm mimicking art, as we started out with. So all this work is, and this has actually been the most fun part about this work, is that it's been very collaborative, and I've really benefited by and learned so much from all the people that have contributed to this. From the Department of Surgery, Raja and Natasha have done a lot of great work making this happen. In pathology, John Higgins and Simon Chen have been essential in terms of helping us design the algorithm and pointing out the nuances. Lin Feng Yang is a bioengineering student who just received his PhD a few weeks ago. He defended his thesis. A small, tiny part of that thesis was helping us out on the algorithms for this. Mac Klinkertorn and Christian Soyasu are two people I hired to help with the technical aspects of the project. Mac is a Stanford undergraduate and has done some of the iPhone app programming already. Christian has helped me with the computer-aided designed images that I showed I didn't talk about the work Sunny Wong is doing, one of our interns. In addition to doing some cool stuff on COVID with us, she's also collecting UNOS data, and we want to combine the UNOS data with the imaging data to try to produce even a more predictive score of early graft dysfunction. And then this whole project has been helped by advice and input from Dr. Young, who's an assistant professor of biomedical data science, and by courtesy of computer science and electrical engineering. We've published a couple, we've written a couple collaborative grants, and we plan to work on some more collaborative grants. So thank you very much again for the opportunity to speak, and I'm happy to take any questions.